Welcome to the Disability Approval Path.
Welcome back to Social Security and Disability, the Approval Path with Deborah Spector, lead attorney and managing partner at Spector & Lance PC. With more than 40 years of experience, Deborah has guided thousands of Social Security and SSI claimants through every stage of the disability process, from the first application to federal court appeals. I'm Evan Mack, and today we're talking about proving disabilities you can't easily see. Deborah will explain what kind of evidence really matters, how to stay consistent, and how to help the Social Security Administration understand what life is truly like day to day. Welcome back, my dear.
Good morning. Good to see you.
Awesome. Ms. Deborah, what kind of conditions are considered invisible disabilities, and why are they sometimes harder to prove to Social Security?
Well, they're pretty obvious. The mental health disorders are invisible disabilities. Pain is an invisible disability. We can't really, there are devices here and there, but we can't really measure pain with a tool. And among the pain categories, I would say the big ones we deal with very frequently are back pain and headache.
If a listener's pain or fatigue doesn't appear on a scan or a test, what types of medical or functional evidence can help demonstrate how serious it is?
Well, having said that, these are invisible. They're actually visible to medical providers. They know what to look for. And there are things that can be done in the office setting, in a clinical setting, and there are measures that are standard across the profession to evaluate symptoms and presentation and other things a provider can observe to reach a conclusion about diagnosis. So in mental health, for example, there's a book called the DSM-5. It gives you the criteria for evaluation of mental disorders, and a clinician will interview somebody and then observe her over time and use the factors that are seen to reach the conclusion. That's medical evidence. That's not a fairy tale that the doctor makes up. That is done in a standardized setting. Similarly, with pain, if a doctor observes a client who's complaining of pain and the doctor doesn't know the cause, there are standards the doctor will go through to come up with some diagnostic impression. Headache, same thing. If there is a brain tumor that shows up on imaging, great, there's your answer to the question. But more often, headache doesn't show up on imaging, doesn't show up on a blood test or anything like that. Again, we're looking at consistent complaints that good clinicians evaluate on a standard. Here's the important thing about pain, though. Pain requires, for analysis by Social Security, a medically determinable impairment. It's a two-step process. So first, you have to establish a medically determinable impairment, something that within the professional sphere that you're consulting is recognized as an impairment and can be shown clinically to exist. Only if that happens will SSA then evaluate the pain. Okay? Without a medically determinable impairment, they will just blow off the pain. It doesn't count. Once there is a medically determinable impairment, however, they will evaluate the pain based on symptoms reported, consistency, regularity, what the claimant has to say, what third parties have to say, and they don't or are not supposed to weigh the extent of the pain against the extent of proof of the medical impairment. So, for example, if someone goes in with an X-ray that shows a problem in the low back, but it's moderate, and the individual complains of debilitating low back and leg pain, as long as she's established through the X-ray that she has a medically determinable impairment, then they have to evaluate the extent to which they're going to consider her symptoms as a vocational problem independently. They can't say you can't be experiencing pain because your X-ray was only moderate. It has to be much more extreme. They're not supposed to make that analysis. It's a little bit in the weeds, but the important thing to take home is you need to prove there's an impairment, and then SSA will go on to evaluate it. And they use, as in everything else, consistency, supportability, third-party corroboration, frequency of symptoms. And how do we tell our clients to prove these up? Journals.
Yeah.
We like journals. Sometimes we submit them as evidence. Often we won't submit them because of the format they're in or they're not helpful, but they tell us what the client's experiencing. And then we have the client write this up in a personal statement. And we also ask clients in almost every case to get us third-party statements too. So you tell me what's going on and also have your husband tell me, your adult children.
Miss Debbie, we often talk about records and keeping things consistent. Can you really emphasize or elaborate to people how important it is to keep these records when you're building this kind of claim?
You bet. And two reasons. The first reason is to prove your case, you need to have a consistent history of the same things reported again and again and again, corroborated medically, corroborated by third party. That's how you put the bricks in to build the case. The second reason is if there is inconsistency,
Mhm.
SSA will use that to justify denying a case. Until a few years ago, SSA used to find individuals not credible. That was the word that was used, credible. And credibility was the standard for deciding whether or not to believe someone when she reported her symptoms.
Mm.
Because that casts a negative light on someone's character, the rules and the verbiage were changed a long time ago. And so what we use now, not that long ago, what we use now is consistency.
Mm.
It stands in for credibility.
Mm.
They will find you inconsistent if there's exaggeration, if there's minimization,
Mhm.
the symptoms, if there's, I don't know if that's a word, if there's minimizing of the symptoms, or if more important, there are conflicts between what you tell your doctor and what you tell the government.
We're talking about these invisible conditions, but for mental health claims such as depression, anxiety, what documentation or statements can carry the most weight with SSA?
Those are hard. We recommend whenever a client can do it, what's called a neuropsychological evaluation for all neurocognitive problems and also for what we call the affective disorders, mood disorders, certainly for psychosis, anything like that. So we ask for a neuropsychological. They can be expensive, and often clients have to figure out a way to pay for them themselves. The government won't, generally. Very rarely will the government order a neuropsych. For mental health cases involving depression, anxiety disorder, we tell the clients, you must see a competent practitioner. Now, it doesn't have to be a psychiatrist. That's ideal. We want the diagnosis ideally made by a psychiatrist.
Right.
But the reality, Evan, is that psychiatrists are few and far between now in our country. They're expensive. They're hard to get appointments with. And most of the frontline mental health care in our country is being provided by advanced practice nurses,
Wow.
often who specialize in psychiatric problems, but
Mhm.
advanced practice nurses, PAs, physician assistants, sometimes they're FNPs, family nurse practitioners,
Wow.
and clinical psychologists, and all the way down the kind of title ladder. Sorry about the dog. All the way down to people with master's degrees, LCSWs, licensed clinical social workers, all the way down to people with credentials like counselor.
Mhm.
And it depends on what the person can access and afford to access.
Mhm.
Um, so first line of business is getting yourself properly diagnosed. If you can, get a neuropsych. Stay with the treatment and be in therapy. We ideally like to see people with mental health disorders in treatment with a psychiatrist and with a therapist, or at the very least, being prescribed medication by an advanced practice nurse, and they can prescribe where we are, or by your family doctor if
Mhm.
they're prescribing antidepressants or anxiolytics for anxiety, and with a therapist. That's
Mhm.
ideal.
Can personal accounts like letters from family, friends, or caregivers help show those symptoms, how they affect your daily life? Could that help your case?
You bet. And we believe strongly in them. SSA, if they're going to deny a case, will say, well, we've looked at the letters from the family and the caregiver and whatever. They're not medical opinions, and we're not giving them any weight. But they have to at least acknowledge that they're there. And if a person has a claim the government wants to approve, those things can be used kind of as the tipping point to get the case approved. So yes, but they will not stand in for medical providers. There has to be medical documentation.
So, Ms. Deb, you work with thousands of claimants. What are some common mistakes people make when describing their pain or fatigue on forms during these hearings?
Exaggerating.
Okay.
I would say exaggerating is the number one problem. I have a 9 out of 10 headache, 18 hours a day. Well, how are you walking to the kitchen?
Right.
That's the case. So be realistic, be truthful, don't exaggerate, and don't minimize. Same thing. We go through our clients' daily activity forms before they're submitted to the government. If somebody says, I never leave my house, we go back and say, really?
Yeah.
Do you go to the doctor? How do you see your therapist? If the therapist is seen on telehealth, we say, put that in there. I can't even go out to my therapist. I do videos. Or same with any other symptom. If on those forms, if a person says, I take care of my dogs and 17 gerbils, we say, really? And do you have any help doing that? And how far do you walk that dog? Do you open the back door while you're in your pajamas and say, go outside? Or do you go out for a 2-mile walk 3 times a day? So we watch those closely, again, for consistency, exaggeration, or failure to emphasize a symptom. I do want to mention that there are a couple of impairments in which SSA has special rules about pain. And they recognize, after intense lobbying, they recognize that there are differences with these impairments. One is fibromyalgia. Fibromyalgia used to be thought of, and some practitioners still think it's primarily a mental health experience that a person's experiencing in trigger points in her body with tenseness. People debate that. There are doctors who believe, no, this is a real problem with, nerve problems. Others believe that it's at least psychologically initiated, which then results in visible tension and knots in the body. Regardless, SSA will say, if you have enough, they're called trigger points, throughout your body that can be identified, ideally by a rheumatologist, we'll find you have fibromyalgia, which is pain. It's a painful condition. So that's one exception. And then the other is called complex regional pain syndrome. And that's a really interesting impairment. We often have a couple of cases active at any given time, or we could go a couple of years without one. And that's when there's, within the central nervous system, we have to assume there's a pain reaction that's way out of proportion to anything that's happened to the body. And one of my favorites I will never forget, too, is a guy who had a crush injury at work, and he had an injury to his finger. And he was then incapacitated indefinitely because his body just responded to it with a complex regional pain syndrome. And it used to be called RSD, something with sympathetic dystrophy, now called complex regional pain syndrome, reflex sympathetic dystrophy. The body's gone berserk because of a minor injury. We also had a client who caught her finger in the spring in a baby crib.
Wow.
And that was it. She was disabled. So Social Security has very special rules for how those are analyzed. And they also do look for physical findings, especially with CRPS. They look for coldness in the extremities. They look for discoloration. There are things they look for. But generally, you need a medically determinable impairment, consistent reports of pain that can be related to that impairment, even though they don't have to be proportional to the extent of that impairment. For mental health, we're looking for consistency, diagnosis, treatment. People have to be in treatment. And again, don't exaggerate, don't minimize. We like journaling. Now, let me say a word about headache. Headache is a particular problem for us and for Social Security. You can't see a headache.
No.
But if you live with someone, if you love someone you don't live with, you can tell. And there are a variety of ways. We see this in third-party reports. Does the individual say to you, I'm having a headache today? How often does she say that to you? When she's struck with a headache, can you tell? When the headache comes on, does she have to leave the room? Does she have to leave the Christmas event? Does she have to leave the restaurant?
Mm-hmm.
How often is she found lying in bed in the afternoon with the
Mm-hmm.
blinds closed? So those are all little bricks that we put in to build the case.
Mm. So, Ms. Deb, how does the Social Security Administration evaluate credibility with all these types of cases? What can listeners do to keep their statements consistent and believable?
Well, again, we've excised the word credibility
Yeah.
because that reflects on our characters. So
Yeah.
they're looking for consistency, supportability.
Okay.
They're looking for in pain cases, headache cases, whatever. What kind of meds are you taking?
Right.
That's a real telling thing. If I have a prospective client call up and say, I have excruciating back pain and I can hardly walk to the kitchen, and say, great, what meds does your doctor give you? And the person says, well, I take some Tylenol. That informs me. It doesn't mean I won't take the case, but it informs me that there's something else going on here.
Do you believe consistency can kind of build credibility? Do you believe like that kind of consistency can kind of give you, you know what I mean? Like give you the illusion of credibility. You know what I mean?
It is credibility.
Yeah.
It is yeah. Consistency is the most important. But we also look at medication, treatment.
Mm-hmm.
If you have back pain, are you using heat, cold? Do you have a TENS unit? How often during the day do you take a break and rest? Do you take hot baths? Do you put
Mm-hmm.
ice on it? And same thing with mental health. How often do you have to avoid crowds, public gatherings, social gatherings? So we're looking for, consistency is credibility, right? And
Mm-hmm.
we joke that, they're used interchangeably. We just don't say the word credibility anymore.
Yeah. Makes sense. It makes sense. For people who have good days and bad days, how can they explain that fluctuation without sounding inconsistent or sounding unreliable?
Early and often.
Mm-hmm. Mm-hmm.
So we have talked about going to consultative exams, and
Right.
I think we didn't mention it when you go to a consultative exam. If you have good days and bad days, tell that doctor.
Mm-hmm.
And if you're going to a hearing, tell the judge. If you're in physical therapy, tell the physical therapist. If you go for a one-time functional capacity evaluation at a physical therapy outfit, make sure you say to them, I'm having a good day today,
Yeah.
but tomorrow I'm going to be in bed all day.
Okay.
And then these are the kinds of things we want to see in the journal and in the personal statements and in the third-party statements. I've been doing this a long time, Evan, and for decades, I didn't ask for client statements unless there was something particular that had to be explained.
Mm-hmm.
Like why I told the consultative examiner that I never had headaches when I really do.
Right.
And I would ask the client for a supplemental statement. Now I ask for them in almost every case. Say,
All
give
right.
me a good personal statement, a good biography,
Right.
autobiography, explain your life, explain your limitations.
Right.
I also say, please, I beg you, do not say, and that's why you should give me benefits. Or that's why
Mm.
I should get benefits, and I don't understand why Harvey down the street gets them. Leave that
Okay.
stuff out. Just
Okay.
the facts.
Finally, Ms. Deb, what's your advice for someone who feels defeated because their invisible condition isn't being taken seriously by doctors or the SSA?
If you believe, this is personal, not speaking as an attorney, but if you believe you have something wrong, physically or mentally, and your doctors are blowing it off, and Evan, you can look at me. This is something that happens often to older women. Yeah. Go find another doctor.
Okay.
You do not have to accept that. If you know your body and your mind and there's something
Absolutely.
wrong, go seek better medical care. Go
Absolutely.
seek further testing. And we both know endless stories of people who have to go to a second, third, fourth doctor
Yeah.
to find cancer, to get diagnosed properly with a bipolar disorder. So don't
Absolutely.
give up with the medical system. Keep going, keep pushing. And, God willing, we'll still have a good Medicaid system this coming spring. There is medical care available throughout the country today. So go find another doctor. Now, if Social Security doesn't believe you, appeal.
Mm-hmm.
Build your medical evidence. Get
Mm-hmm.
every brick you need to build your case. Keep appealing. We've talked many times about this, but 60 to 70% of initial claimants are denied.
Mm-hmm.
And on the first appeal, almost 90%.
Wow.
Don't give up, keep appealing.
It's
And
incredible.
that's the key with the government. And if you need to, go get some help to
Yeah.
continue appealing, but don't give up. And at the same time, build that case brick by brick by brick. Let me say one last thing, especially with mental health disorders. but also with some physical disorders.
Okay.
Sometimes we'll give people the advice, you have to go get this diagnosed. You have to get capable medical evidence about this. And people will say, okay, great, I did it. That's not enough. I mean, unless, God forbid, the impairment is something like loss of both limbs.
Yeah.
That's not going to change. You know, if it's mental health, if it's a pain disorder, you have to stay in treatment. Keep showing that you're trying to take care of yourself and the situation. I said one last thing, but one last thing. We have a doctor in our community who says to people, especially older people, don't ignore the small stuff.
Ms. Deb, you were saying, I thought you sounded like Columbo for a second when you said one more thing.
One more thing. Don't ignore the small problems.
Yeah.
Go get a medical answer if you know something's wrong.
All righty. Ms. Deb, thank you so much.
Pleasure.
All right. That's it for today's episode of Social Security and Disability, the approval path with attorney Deborah Spector. If you or someone you know is navigating a Social Security or SSI claim, visit spectorandlens.com to learn more. And as always, don't forget to like, subscribe, leave a review, and share this with someone that might find this information helpful as well. Thank you so much, and we'll see you next time.
So long. Good to see you, Evan.
Thanks for watching. Be sure to hit that like and subscribe button and leave us a review in the comments.